Hello again, and welcome to the next series of our endocrinology part of the learning. Today, I'll be covering an introduction to diabetes mellitus. My name is Dr. Betty Dube. My pronouns are she, her, and I'm a certified diabetic educator. I've included a captioning statement just to let you know that if you are using the captioning that will appear on this video, it is up to 90% accurate. Take a few moments to read the full captioning statement. So, by the end of this session, you should be able to describe the epidemiology, etiology, and pathophysiology of diabetes mellitus. We'll be able to identify the signs, symptoms, and characteristics of the different types of diabetes. And then I'll move on to describing the epidemiology, etiology, and pathophysiology of type 1 diabetes mellitus. And we'll discuss the diagnosis pathway of type 1 diabetes, and we'll also briefly describe the main treatment of type 1 diabetes. So just to recap again, I thought I would include this slide with the pancreas. So before we dive into diabetes, let us revisit the pancreas. The organ plays a central role in the glucose regulation through the endocrine and exocrine functions. Today, our focus is in the endocrine component of the pancreas. Specifically, the cells that are responsible for insulin production. As you can see on this slide, the pancreas does produce a few different chemicals, if you like. So we have the insulin there, we have glucagon, we also have vasoactive intestinal peptide, and we also have the somatostatin. These are really important when we get into the pharmacotherapy of diabetes as a condition, because the newer therapies have started targeting these other parts of the function of the pancreas. Next, I would highlight the two parts of the pancreas. So we have the exocrine part that tends to deal with the digestive system, and the endocrine part, which mostly deals with the main hormones that do malfunction in diabetes. The islets of Langerhans contain several cells, but the beta cells are the key ones that produce insulin. Understanding these cells' functions and what happens when they fail is essential at understanding diabetes, and specifically type 1 diabetes. So what is diabetes mellitus? It is the most common of the endocrine disorders. It is a chronic metabolic condition characterized by hyperglycemia due to impaired insulin production and secretion with or without insulin resistance, causing an impairment in carbohydrate, fat, and protein metabolism. So what does diabetes mellitus mean? The name is a Greek, the part of it, diabetes, is a Greek of origin, meaning siphon or to pass through. And the second part of it, mellitus, is Latin, meaning sweet, because in diabetes, excess sugar is found in blood as well as in the urine. So diabetes was first recorded in English in the form diabetes in the medical text written around 1425. It was in 1675 that Thomas Willis added the word mellitus to the word diabetes. This was because of the sweet taste of the urine. The sweet taste of the urine had been noticed in urine by ancient Greeks, Chinese, Egyptians, Indians, and Persians, as is evident from the literature. So this was really interesting for us to know. So here is a 2-minute video you'll need to watch on your own time that describes what diabetes is, and it's based on the Diabetes UK website. I've also I thought that was a very good description of diabetes, just under in 2 minutes. So I thought I'd include that here so that we could watch it together. So moving on, there's another video I'd like you to watch in your own time. Okay, so we'll move on to insulin. So what is insulin? Insulin is a hormone produced by the pancreatic beta cells. That's important for us to know. It regulates blood glucose by facilitating uptake of glucose, amino acids, and electrolytes into cells. Insulin has a short half-life and is metabolized primarily in the liver and kidneys. A deficiency leads to increased hepatic glucose output and reduced peripheral uptake, and that is the hallmark of hyperglycemia. So it's important for us to note here that it's not about just the metabolism of glucose as we would probably have known, but it also impacts or influences and has a role in the transportation of other uh, chemicals as well, as noted here. I thought I would include a recap here real quick to remind everyone what a hormone is in case you didn't get a chance to have a look at the other part of the series where I introduced the endocrine system, but also just to remind everyone the differences between the hormonal and the nervous system. Okay, so what happens in diabetes? Just as described in the video there, you start with an impaired insulin secretion, and this results into resistance to action of insulin or just an impaired secretion of it. Then you have reduced glucose utilization peripherally. You have increased glucose output in the liver because there isn't the conversion of glucose to glycogen. That leads to excess glucose accumulation in the circulation, and hyperglycemia occurs, which stimulates the pancreas to produce more insulin. And this is that part of that negative feedback mechanism, which I explored in the first part of the series. So have a look at that. If you didn't understand the negative feedback, go back and have a look at that short video. So I'll now delve into the pharmacoepidemiology of diabetes around the world. And these are statistics from 2024. So globally, around 589 million adults are living with diabetes. And this number is projected to rise to almost 853 million by 2050. So also, most people with diabetes live in low and middle income countries, and over 40% of these people remain undiagnosed. This highlights the scale of the global health challenge. There's a main awareness gap, as mentioned in this slide here. And again, by 2050, around 1 in 8 people globally will have diabetes. So it's a major health issue that has already reached alarming levels to date, and it's one of the fastest growing global health emergencies of the 21st century. These statistics I captured from the International Diabetes Federation. Okay, so again, another snapshot here. It's exactly the same statistics there, but this breaks it down to the type of diabetes and telling us the numbers and how type 2 diabetes specifically that we'll cover in the next part of the series, and how that can actually be preventable, unlike type 1 diabetes that I am covering in this section that we still have a lot to learn about. Okay, I thought I would also include here this burden, that it has a big burden to the health system, and it contributes significantly to the global health expenditure if unmanaged. Okay, so then when we go look at the global picture, we said 1 in 4 adults are living with diabetes, and these have been shown to be aged over 65, and it's estimated that over 600 million have impaired glucose tolerance. So they're not quite diabetic, but they already have some impairment in their glucose in the body, and around $1 trillion is spent on diabetes, and this accounts for around 12% of the global health expenditure. Just over the last few years, over 3.4 million people, like this is all in 2024 actually, over 3.4 million people died as a result of diabetes, which corresponds to almost 10% of the global deaths from all causes. So this is quite alarming. Okay, of the many, many millions with diabetes, around 10 million are living with type 1 diabetes. Okay, and it is estimated that in one in 5 live births are affected by some form of hyperglycemia of pregnancy. Again, that's a big, big number overall. So again, I thought I'll include this slide with the trends and statistics from the International Diabetic Federation, just more to paint that picture that it's not just, it is a global problem, and these are the statistics. And as you see, it's been rising year on year for the last many years, as listed on this slide. Something just for us to be aware of. Take a few moments to have a look at the slide. Okay, so now I'll move on to diabetes in the UK. So around 5.8 million people have living with diabetes in the UK, and this is termed an all-time high. Data show that almost 4.6 million people in the UK live with a diabetes diagnosis, and then around 1.3 million of these people could be living with type 2 diabetes, but they actually don't know. The figures have risen year on year by 100,000 of people compared from 2023-24 down up from 2022-23. So if we just try to break it down, in the UK, how many people are living with type 1 diabetes? So 8% have type 1 diabetes, over 90% have type 2 diabetes, and the remaining others, around 2%, have the rare types of diabetes. So when it comes to Scotland, around 6.7% of the population have been diagnosed with diabetes, and over 45,000 people remain undiagnosed. There's over 500,000 people who are at risk of type 2 diabetes, and there's a future projection that by 2035, almost 500,000 people will be living with diabetes in Scotland, and this is doubled in the last 10 years. Okay. And then it's actually documented the incidence of diabetes. 48 people are diagnosed with diabetes every day. So that's quite significant if you look at it. So I thought I'll mention the cost the diabetes has to the NHS, and this is the NHS. Mostly our numbers are taken from the NHS England, but diabetes costs and prescriptions for the NHS 2024-25. So the total cost of diabetes to the NHS was estimated at 10.7 billion, equating to 10% of the entire NHS budget. Again, similar to what the global numbers have shown. Cost of complications are approximately up to 80% of the spending, and largely from preventable complications. Prescription-wise, it's around 77 million. Again, quite significant jump from the 50 million in 2015. And prescription spending is around 1.92 billion, again, increasing by around 15% year on year. And there's a cost there showing us the spending as well as number of patients. Again, these are English figures, and it says that they've increased by around 7% from the previous year. Again, can be extrapolated to the other countries, and because, as you've seen, these numbers match the global scale as well. So when it comes to classification of diabetes, there are two main types of diabetes. We have type 1 diabetes, which accounts for around 80% of the 8% rather of the cases. And we have type 2 diabetes, which accounts for almost 90% of all diabetes cases. But then we have the rare diabetes presentations, which account for around 2%. And these are rare. They're listed here. We have type 3C diabetes, which results from damage to the pancreas. We also have gestational diabetes, which is glucose intolerance, which is first recognized during pregnancy. Then we have LADA, which is latent autoimmune diabetes in the adults. And then we also have maturity onset diabetes of the young, also known as MODY. It's caused by a single gene mutation. That's really important to know. We also have neonatal diabetes diagnosed in an infant who's less than 6 years old. We also have these other ones listed here. Some are drug induced, some are linked to other conditions. And there's also, it's been documented, the classification, misclassification due to misdiagnosis, commonly as type 2 diabetes, occurs in around 40% of people. So it's really important that we're able to capture the type of diabetes the person has so we can support them accordingly. Okay, I thought I'd include this table here. Again, it's just a snapshot. And again, as they said, like the MODY, where you have a single gene mutation, they've managed to pinpoint exactly what part of the mutation that is. Take a few moments to browse through this slide. Okay. So there are also some other causes of diabetes as listed here. So it will be caused by diseases of the pancreas, I think I've mentioned already. Also, it could be endocrine disorders. It could also be genetic syndromes, could be chemical induced. Right. So there are others here that have been documented over the years. Again, still a lot we still need to learn about diabetes. Okay, so just to recap what I've discussed so far. So we've covered the UK or global UK and Scotland specific epidemiology. We've gone through the NHS cost implications, and I've also gone through the full etiological classification of diabetes. Okay, you should now be able to distinguish between the major types and subtypes of diabetes and also understand the scale of the condition globally as well as nationally. Okay. So let's move on to diagnosis of diabetes. According to the World Health Organization, WHO, the diagnostic criteria include a fasting venous plasma glucose, FPG, of equal or higher than 7.0 millimoles per liter. Okay, very important to note the units here because these can be represented differently depending on what resource you use. So in the UK, we tend to use these units, but in the US, they sometimes use other units. So important for you to match what you're looking at with the units that they are presented as. And then also either the fasting. So fasting is when somebody has not eaten anything. Normally it's at least a minimum of 8 hours. I think that's what they say, but it depends on the lab as well. So that's important for you to note. And also the venous plasma glucose of above 11, equal to or above 11.1. Okay. And this is measured, can also be measured at least 2 hours after a 75-gram oral glucose load, known as the oral glucose tolerance test, OGTT. And this is a common test that can be done. I think in the UK, it is done in pregnant women at some point to rule out that gestational diabetes. Okay, and here's a snapshot of the different types of diabetes. So the symptoms included, so criteria for type 1, type 2, and gestational diabetes. Again, as I said, for the purposes of learning for this module, we'll only be focusing on the most common ones, type 1, type 2, but we've also mentioned here gestational diabetes. Okay. So with regards to NICE adds also an A1H hemoglobin, glycolated hemoglobin, also known as HbA1c, of above 48 millimoles per mole. Again, this is an important unit because for many years we've been representing it as a percent, but of late, I'll say in the last 5 years, we've opted to go down to the bits where we represent it as millimoles per mole. So again, it's important for you to know what numbers what units are being represented. So we have those, and then the random one is termed diabetes if it's above 11.1, but also in the presence of symptoms. Okay. So for suspected type 1 diabetes, which is what I'll be covering in the next part of this talk, is diagnosis is made clinically and considers signs such as ketosis, rapid weight loss, Normally, the patients are below 50 years of age. They have a low BMI of less than 25, and most of them also sometimes have an autoimmune history. There could also be autoantibody testing that can be recommended to confirm type 1 diabetes. But again, this is not routine and it varies per locality. Sometimes C-peptide testing may be used if classification remains uncertain. Remember, I did say up to 40% of people end up being misdiagnosed, and this could be used to confirm the type of diabetes they have. So now I will move on to type 1 diabetes mellitus. Okay. So type 1 diabetes mellitus results from autoimmune destruction of the pancreatic beta cells. So both genetic and environmental factors contribute, but the exact trigger remains unclear. Beta cells lose loss progressively slowly, but clinical onset is rapid once insulin production falls below 5 to 10%. So again, it could happen at some point because we don't really know when or how it happens, but then we only get that acute presentation or those acute signs and symptoms when there's fall in less than between 5 to 10%, so less than 10% of the function of the beta cells in the pancreas. So ongoing research there is ongoing research at the moment investigating ways to prevent to preserve that beta cell function. Because as I've said, you need for it to go below 10%. So in theory, if we could keep that functionality above 10%, then potentially the person would not progress. But it's all still a work in progress. So when it comes to the statistics of type 1 diabetes, remember I said it's around 10% of the population with it. So these are just the figures. And then the projections that they've done. So globally in 2020, there was around just under 9 million. And then by 2026, the new estimate is around 11 million. Okay. And then by 2030 will be around 14 million. And the projection by 2040 will be 17 million. So it's predicted that this trend will be increasing. Okay. So when I mentioned ongoing research with regards to type 1 diabetes and early, so in the UK, we have the ELSA trial ongoing right now, where they're screening children for early stage type 1 diabetes just using a finger prick test. I'll include some resources on the Moodle page for if you want to go and have a look. And then there's also a EU-approved immunotherapy to delay the progress from stage 2 to stage 3 type 1 diabetes. So this is how they're trying to conserve or preserve that beta cell functionality with a drug called templizumab. And then we have the beta preserve trial, which now is a phase 3 trial testing the templizumab in newly diagnosed patients aged 1 to 25. And then we also have another trial called the Fabulinas trial that's investigating a drug for glucose control in newly diagnosed type 1 diabetes. This year, we also have a Grand Type 1 Diabetes Challenge led by Professor Sarah Richardson that will focus on the immune reset and beta cell regeneration, which is quite important. As I said, you need that once the beta functionality reduces below 10%, this is when type 1 diabetes presents. And then we also have a global regenerative therapy, such as the stem cell and the CRISPR-based approaches to restore insulin production. So a lot of work is ongoing at the moment because we do know it's still a lot of unknown factors, sadly. But again, we are hopeful that one day the research will become bring some hope at the prevention of type 1 diabetes. So based on the clinical grounds in adults presenting with hyperglycemia, people with type 1 diabetes typically, and this is typically not always, have more than one of these symptoms here listed. So ketosis, rapid weight loss, age onset under 50 years of age, and they're typically with a BMI of below 25 kilograms per meter squared. There's also a personal or family history of autoimmune disorders or autoimmune disease. Okay. But do not use age or BMI alone to exclude or diagnose type 1 diabetes in adults. So that's really important. You must also consider the possibility that other diabetes subtypes and also revisit their diagnosis at subsequent clinic reviews. So this is really important. And further investigations should be carried out when there's still uncertainty. In adults, they could conduct diabetes-specific autoantibodies that can be measured. Okay, and then we could also measure the serum C peptide, which is not routine yet, as a confirmatory test. So have a look at these resources here, and also NICE NG17 does review this diagnostic criterion for type 1 diabetes. So, in the pathophysiology of type 1 diabetes involves the acute deficiency of insulin, which leads to unrestrained hepatic glycogenolysis and gluconeogenesis, with a constant increase in hepatic glucose output. So, glucose uptake is decreased in insulin-sensitive tissues, right? So, therefore, hyperglycemia follows, either resulting from metabolic disturbance itself or secondary to infection or other acute illnesses. There's always an increased secretion of the counter-regulatory hormones. Remember that negative feedback mechanism, but one part of it now is malfunctioning. So we have the glucagon, cortisol, catecholamines, and the growth hormone can also be impaired. And all of these tend to increase hepatic glucose production and hence that lingering hyperglycemia. So symptoms present over a course of days or weeks in children and adolescents, and these include polyuria, polydipsia, weight loss, and lethargy accompanied by hyperglycemia. Again, you must always remember the difference between the signs and the symptoms. The signs will include profound hyperglycemia with a random blood glucose of over 11.1, typical but not always, with the following symptoms. So you have ketosis, ketonuria with or without ketoacidemia. So there's ketones in the blood and the urine or in the breath as well. We have age onset younger than 50 years of age. We have a low BMI, family history of an autoimmune disorder, and sometimes the presence of the autoimmune antibodies. Okay. So here's just a quick summary of the symptoms of type 1 diabetes. So abnormal thirst, frequent urination, lack of energy, fatigue, blurred vision, constant hunger, sudden weight loss, and bedwetting in some instances indicates that a child or an adolescent may have diabetes. So patient-centered care is really important here. Typically, it presents with a feeling of thirst. So thirst is normally just the brain's way of warning us that one is dehydrated because they haven't drunk enough. But with excess and persistent thirst, so the polydipsia, it's a sign that there's an underlying problem such as diabetes. Not always, but most of the time, because there's that constant, persistent hyperglycemia. So passing more urine more than usual, particularly at night. So that's polyuria, and that explains why some people present with bedwetting. And you're always feeling tired because you have that hyperglycemia. There's also a bit of weight loss and loss of muscle mass and persistent infections such as thrush, just because there's an impact on the immune system. The symptoms of type 1 diabetes develop quickly in young people, so it could be a matter of hours or a matter of days. In adults, it may take up to a few weeks. And I've included here a quick summary of this for you to review. So significant metabolic abnormalities are present at when somebody presents with type 1 diabetes. Okay, so around 20 up to 40% of patients present with diabetic ketoacidosis after several days of polyuria, polydipsia, polyphagia, and weight loss. In many, this is a medical emergency because it's presenting symptoms of a diabetic DKA, which is the diabetic ketoacidosis, present as nausea, vomiting, abdominal pain, dehydration, and shortness of breath. This is secondary to the respiratory system trying to compensate for that metabolic acidosis caused by ketones, and in extreme cases, this can actually progress to a coma. So without prompt treatment, DKA can be fatal. So I've included here that DKA management will be covered at a later stage. So this will be part of the series under diabetic complications. So again, I'll just include it here, like when it comes to our diagnosis of diabetes, both type 1 and type 2, but in this case, type 1 diabetes, these will be the criterion that we'll use. Okay. And specifically here, I've just had to list this here again as just more to emphasize the point. So you have based on clinical grounds, hyperglycemia plus 2 out of these 3, short history of symptoms, ketones, and rapid weight loss, very important. Okay. So goals of treatment for type 1 diabetes are to improve symptoms, to reduce the risk of microvascular and macrovascular complications, reduce mortality, and certainly improve quality of life. So early treatment with near to normal glycemia reduces the risk of microvascular as well as microvascular disease complications, and aggressive management of cardiovascular risk factors will reduce the macrovascular disease risk. So appropriate care requires goal setting for glycemia, blood pressure, and lipids, regular monitoring for complications, dietary and exercise modifications, appropriate self-monitoring of blood glucose, which is also not named called SMBG, and close routine lab assessment. So that's really important. Again, the complications will be covered in another week. Okay, so next we'll be covering insulin. But again, I would like to remind you that if you have any questions regarding this aspect of the series, please post your questions on the module discussion forum. I look forward to continuing learning with you. Thank you for completing this part of the series.